All right, how am I doing for sound? Sounds pretty good to me. All right. Okay, so I'm just going to ask everybody to come on in and take your seat because we are just a tad bit behind. And as you all have seen, the sessions are really packed. And this session is going to be the same because we're talking about women's health. And you all know that that is a huge topic, right? So my name is Candace Jingles. I am a member of the North Carolina Council for Women. I've been a member since 2018, and I'm going to be the panel moderator for today. And I'm going to start up front and say, hey, I'm a data person. So those of you that don't like charts and don't like data, I'm sorry, but just remember there's not going to be a test in the end, so you don't have to worry about really knowing, memorizing the numbers. And today is really not even about you studying the numbers as much as it is about you studying the comments that I will have on these slides. The other thing that I want you to remember is that our focus today is going to be women's health and aging, specifically talking about chronic diseases, how those chronic diseases show up when you start to overlay things such as age, race, geographical location within the state of North Carolina. Okay, I have a very esteemed panel here. I am thrilled at the work that each of them are doing and what they're going to share with you today. I'll introduce each of them individually as we start through our questions. One of the things I'm supposed to remind you of today is that we'll have time for Q&A at the end because it is really a packed panel trying to share as much information with you as possible. There will be a series of note cards that will be passed out somewhere around the 2:15 to 2:30 time frame. We will collect those note cards so that we can select questions from the audience that the panel will help you answer today. Okay. All right. Are you ready? The first data slide. So in 2019, the Council for Women, we published a report that was the status of women in North Carolina talking about health and wellness. That report concluded that North Carolina was among the worst states for women with heart disease, stroke and diabetes mortality rates. It also concluded that when you looked at sexually transmitted infections, that we were in the top 10 in terms of the number of reported cases. These were all contributors into the Institute of Women's Policy Research, concluding that our state deserved a D in 2019, again, for women's health. So 2019 is a little bit of ways to go. You've heard a lot today about the things that have happened in the state since, and several of those things were actually recommendations coming off of this report. You'll hear today, though, that there is much more that we can actually do. Couple of things also that were in play at this particular point in time is that 13% of the women in North Carolina remain uninsured. And then we already talked about the disparities that we're seeing when you looked at things like race, location, etc. Okay. All right, a grade D. Has anybody's parents ever accepted a grade D? My parents barely accepted a B. My mom is sitting up in the front, guys, so so anyway, so grade D, right? Not acceptable, I think, by most of our standards. So this chart is looking at those top 4 chronic diseases that showed up in the report and looking across race, as well as looking at the fact that heart disease actually shows up as being the #1 killer at that time in the state for women. You can tell by the bars that in each of these categories, women of color led the number of deaths in terms of mortality rates. Coming forward, 2022, are any of you familiar with the Center for Women's Research at UNC Chapel Hill? Yeah, so back in 2019, we weren't aware that, hey, they have a report card too. And what's great information they have readily available to you that a university like UNC is actually doing research on women's health. What UNC had to say and conclude about women's health, I've got a little bit of a snippet over here in the box, that after age 65, more than half of the women in the state were suffering from 2 chronic diseases or more. Wow, right? Who knew? So heart rate mortality increases substantially every decade past the age of 55. I don't think I knew that either. And if I showed you the numbers to understand what is really meant when we say dramatically increases after the age of 55, guys, we're talking about things, numbers in some of these categories that are 5, 6, 7, 8 times the amount of increase in your risk than when you are younger. Then 20% of the women in North Carolina are living in poverty. That's at that 100%, I think, of the poverty line, and another 10% are very close. Almost 30% of the women in North Carolina living in poverty. 25% of the women in North Carolina are age 60 and above. That 60 and 65 gets used a lot in these different measures, so I have to go back and remind myself which one we're talking about. So just bear with me if I get it flipped around from what's on the chart. But what's on the chart is actually accurate here. Understand the aging population in North Carolina is actually growing, and it's growing rapidly. So this 25% won't be that this time next year, okay? So this is the reason why we want to talk about chronic disease and aging in this particular session today. UNC also concluded that emerging issues when it came to women's health were poverty and aging. Didn't know that at the time that we chose to put this particular panel in this program, but boy, were we really aligned and sensing the right things. All right. So are you ready for the discussion? All right, if you all are ready, I'm going to take a seat here. Thank you. All right, I'm going to take a seat here, and we'll start to go through our Q&A for our panelists. Just a little bit of time to get organized here.
Hold your mic so you can use both hands.
All right. All right, thank you. Thank you, Lyric. You're so helpful. Okay, so the first panelist I would have is Senator Sydney Batch. And many people already know her, but she actually represents District 17. And Sydney she spent a lot of time, actively creating policy. This is a policy conference today. So, to have somebody like Sydney here, who's been very active in writing bills and creating policy, I consider to just be really icing on the cake. So, and several of those are aligned with increasing women's health and the health of family. So two of the bills that she actually has that are still active and progressing through, hopefully to become law, is the North Carolina Paid Family Medical Leave Insurance Act, as well as the breast cancer diagnostic imaging reform. And so the question that I have for Sydney and what I want her to share with us here today is give us just an overview of, especially that the breast cancer diagnostic imaging reform. Give us an overview of that bill. Tell us a little bit about where it's at and educate us just a little bit. I know that might be a tall order, but just a little bit in terms of what it takes to go from bill to law.
It's good to see all of you. So just by way of background, breast cancer is really important to me. I was diagnosed in 2019 under the age of 40 with breast cancer. And what you have seen, and not surprising to you all, everyone in this room knows somebody that has been touched by breast cancer. And disproportionately now is also affecting younger women and also women of color who have delay in services, and also women in rural North Carolina. So when I was going through my treatments at UNC, one of the things that was really evident to me is that you saw all these women from across the state that had to drive to Chapel Hill and leave their homes to come and get care because we waited too long with regards to Medicaid expansion, hospitals closed left and right, and women are having to, of course, recover and get their treatment far from their homes, having to, of course, give up work and also be in a position in which they have to be away from their families. And so it's a passion project of mine, but also it ties into to the paid leave, because 12% of North Carolinians have paid leave, right? So 88% of people are walking around in North Carolina without access to leave. And so when you're sick or when your loved one is sick, people are living paycheck to paycheck and will lose their jobs. What ends up happening is many of those women just choose not to, they delay treatment and they don't get it. many who did not have health insurance until recently with Medicaid expansion. So it's a domino effect as to how all of these policies work. I can tell you one of the most effective policies is, or one of the most effective ways to get legislation through is that you have to be a person who just doesn't care about credit, right? And like women, and there are not a lot of us in the legislature, less than 25% of us, many women are not trying to be or peacocking and telling everybody what they're doing. We're just doing the work, right? And so I consider myself a peahen. And I know that until recently, I have been in seats where they would not give me credit because the party in charge wanted to make sure I didn't come back. And so I just went ahead and said, plagiarize my stuff. I don't care, take it. But so long as we actually get legislation passed, that's the most important. And so you have to build a coalition of a number of members that you're working with in order to try and get legislation through. And it's not just the legislator who you actually have to work with. You have to work with a lot of lobbyists and other organizations. And so with regards to the diagnostic breast imaging bill, of which if you have dense breasts, PSA out there, you have dense breasts, you should probably ask for an ultrasound or an MRI. And a lot of women have dense breasts and it misses a lot of cancers. And so one of the things that's happening is that insurance companies many do not actually consider that diagnostic. So you have to pay $720 for an MRI. I had to do that after having breast cancer, still had to pay for my darn MRI to make sure I didn't have a recurrence recently, right? And so right now we're putting price tags on women's heads to basically say we're worth $700, knowing good and darn well that we are obviously worth more. And so I've worked with insurance companies, other legislators, and other organizations like Susan Komen and other breast cancer awareness organizations to try and push the legislation. I will tell you this in closing, and it's really, really important with regards to how we can use our voices. I asked all the insurance companies to come, private insurers, and I said, come, let's meet. And the great part is that even when you're in the minority party, people still show up if you got a name, right? So I walk in on a Tuesday morning, and what do I walk into? A room full of all men. And I said, you know what I wanted to do today? I wanted to wake up and spend my morning talking to a bunch of men about breast cancer. And they all were very awkward. And they were like, oh, yeah, the optics are bad. I was like, don't worry, don't worry. Next year, when I run my testicular cancer bill, I'll just make sure women are in the room. Okay. So what I will say in closing is that you have to be dogged, you have to be determined, and you have to bring in other individuals from all different walks of life in order for us to get legislation done. And at the end of the day, it has to be about somebody else other than you, because you're oftentimes, especially if you're in the minority party, going to get in the way for legislation to be passed.
What an awesome response. Yeah, as Senator Batch went through, hey, here's what it takes. I thought about just in my own career, I'm like, wow, not necessarily always having to have the credit. Yeah, sometimes you don't get the credit at all. And we know that as women, mothers, grandmothers, we know that well. And hey, you're worth more than $700. I totally agree. Thank you so much for that. That was wonderful. So we have Dr. Vicki Fowler here with us, just another awesome and dynamic personality. And so Dr. Fowler is part of the WaitMed Physicians practice, thank you, system. And she is a family medicine practitioner. And so this spent right much of her time working with women and helping to manage chronic diseases. So this is a special passion for her as well. So the question I have for you is that we see that the mortality rate for a lot of these chronic diseases starts to really, really magnify with age. And so, we have certain measures such as maybe the early detection, such as the bill that was just discussed. But, you're in the trenches day to day. You're where it all really happens in the doctor's office. And so tell me from your perspective, what do you see what else do we need to do to reduce the risk and improve the health outcomes for older women?
Thank you for that question. It's working. Okay. Thank you. And thanks so much for all of you being here today. Yes, I am in the trenches, which I love, and my trenches have changed over my career. So the first half of my career, I was in rural North Carolina, in the very far northwestern county. And so that was my hometown. So I really have had the opportunity to take care of women throughout their lifespan and across the state pretty much. And what I really think is critically important to think about as women is that we're not the same as men in so many ways, and our hormonal balance throughout the day and throughout the month and throughout our lifetime impacts our health. So we're at a really good time in medicine where a lot of women are basically coming forward and wanting more research to look at the effects of menopause. And so the question initially it was proposed was, why are so many women dying with cardiovascular mortality and some of these chronic diseases as they age? And as a physician, you know, the simple answer is, well, we're all getting older. But for women, the menopause transition is a time when much of the cardioprotective benefits of estrogen that we had earlier in our life is gone. And we start then seeing fairly rapid increases in cardiovascular mortality. And there's a lot of research looking at those effects. When we think about chronic disease and the things that are killing women in North Carolina, number one is cardiovascular disease. And I just want to make a point of saying that includes strokes, heart attacks, and heart failure, as well as other issues like heart arrhythmias. That is the number one cause of death for North Carolina women. Number two is cancer. And I would be remiss not to mention the two cancers that are really passion projects of mine as well. My hobby is fighting cancer with an organization that I belong to here in the state, the A4C. And number one, the statistics, I like data too. Statistics show that there will be over 6,000 women in North Carolina diagnosed with breast cancer this year, and 1,000 of them will die. Interestingly, there will be over 4,600 women diagnosed with lung cancer, but over 8,900 women in the state of North Carolina will die of lung cancer this year. The point is, we are doing a really, really good job, not a great job or a perfect job screening for breast cancer. And we are across the country, and especially in North Carolina, doing an abysmal job screening for lung cancer. So number one, that we have a lot of work to do. Now, what we can do, I would say this, the good news is there's a lot we can do to help improve women's health as they age. And the bad news is there's a lot we must do, and it's really an imperative that we do this. So I'm really excited about this conference. And the fascinating thing as a physician practicing for over 25 years is to learn that only 20% of the impact in a woman's health is what I do in the room with the patient. 20%. Now, it's important that people have access to care, and it's really important that we as women have a compassionate, caring healthcare provider that will listen to us when we are speaking. I'll stop there for a moment to pause. Okay. So, yes, and I'm a patient as well. So that's really, really critical that we have access. But more of the social determinants of health and the behavioral practices affect our health. And we as women, 80% of the medical decisions in a family are made by women. We have the power to guide the health of ourselves, our family, and our children moving forward. And it is hard to believe, but true. Diet, exercise, sleep, and emotional wellness are more important than a pill that I'm going to give you in the office, which is somewhat shocking, but true. And so there are so many things that can be done. We'll talk a bit more about policy issues later, but just knowing that every single person in this room can go home, look in their cabinets, look in their kitchen, and look at outside their homes and see, am I in a place, do I have access? Do I know people who need access to healthy food and places to exercise? Sleep is critical, taking care of ourselves. And then every patient that comes into my office every time is queried about their social determinants of health. So if you have housing, financial security, if you have access to food, if you have access to health care, those are the main factors. So, and cardiovascular mortality and cancer mortality are both lowered by making those changes.
Right. Wonderful. Thank you. Yeah, so I love how Vicky's perspective, because it keeps us real, right? So in terms of being able to make policy recommendations, but the perspective of someone that really sees it and lives with the patient every day. So thank you so much for that. Okay, so one of the things that I want to point out as well, we talked about some of the disparities that show in the data when you start to look at geographical location. So here's another chart for you. All right, you're not tired of charts yet, right? So this one is a good one. And this one was actually provided by the North Carolina Rural Center. And looking at some of the different categories of healthcare professionals, and especially focusing on this bar over here when it comes to physicians that might be needed to help people manage some of the chronic diseases that we have been discussing. So looking at locationally, so comparing the rural to suburban to urban. So, and just even just noticing the difference in the bars, right? So rural is probably, a third of what the actual urban availability is, with suburban being, maybe 2/3 of what the urban availability is. And so, on top of there being a physician shortage, which we haven't talked about, but just take it as fact, and you can study it when you get home, there is a physician shortage right now. So on top of there being a physician shortage, there's also, it's accentuated by this disparity in geographical location. So I have a question that we've posed around access as a result of knowing and having some of this background information. So I want to go back to Senator Bass first on this question, and I have the same question that I would like Vicki, Dr. Fowler, to help us with. So, how can policy help address issues that we find and how they manifest when you start to look at race or age or geography, right? Especially when we see this disparity in physicians. People ask the question of, well, why policy? How can it help? So can you give us some of your perspective of how you think policy can help in either one of these disparity areas?
Yeah, so I mean, if you look at the map and you see rural North Carolina, you realize that a lot of North Carolinians are going without care. We have maternal deserts. We have, I mean, there are a number of places in which you have to drive 2 hours to get to a specialty provider, right? I mean, we have the majority of counties in North Carolina don't even have a psychiatrist. And this is the reality. And again, I wanted to be a doctor, but chemistry and calculus told me elsewhere. So what do people who want to be doctors do? Go become lawyers. But my parents are physicians, and so is my sister, and they talk about this the entire time. When we put ourselves in a position where especially doctors decided not to figure out how to run a business and learn the business aspects and turn it over to MBAs, that is when healthcare went and actually caused a ridiculous amount of problems, because now it is being treated as a business instead of being treated as obviously the profession it needs to be. So when you give a doctor 15 minutes to talk to somebody in their yearly appointment about all of the other ailments that they may have, you're not going to get best outcomes. The other problem that you have is medical school is expensive as all get out. So once that person finally graduates, they have to have patients who can pay. Well, when we didn't pass Medicaid expansion and waited over a decade to do so, hospitals started closing. People in rural North Carolina disproportionately do not have as much money, do not have insurance. And so how is a doctor going to make money in a hometown that they want to return to if they're in a situation in which they don't even have any patients? They have to pay those student loans back. And one way or the other are going to have to make a living. The other thing that they want to do is make sure that their family and their children do well. Well, if we are actually giving a disproportionate amount of resources to urban areas and that the rural areas don't get broadband, don't have high quality education for their kids, they're not going to stay in those areas. And so we have to look at a systematic change and a holistic change on how we actually are looking at social determinants of health, how we're looking at treating the whole person, how we're looking at mental health treatment, et cetera. But you also have to make sure that that doctor wants to live in that rural area, because no offense, but a whole lot of people aren't moving to Paquemmons. Okay. That's a county for some of y'all who don't know that, right? And so there are a handful of people there, but they don't want to leave. They don't have their Wegmans, right? They don't have a dine-in movie theater. We have to make sure that rural North Carolina is a place that people want to live and that they want to stay. And I tell some of my colleagues who represent rural areas, I said, I don't know why I love your constituents more than you love them, because I'm trying to get them services. I'm trying to get them help. I'm trying to get doctors to go there. And we have sponsored bills, and Dr. Fowler can talk about the programs that we already exist, but we need to expand on making sure that we do loan forgiveness for people who want to go into our tier 2 and tier 3 counties, so that they can go ahead and say, you know what, we're going to go ahead and allow for you guys to be in a situation where you guys can make your money And you can get loan forgiveness and stay in a place where you were homegrown and how you will remain. So there are a lot of policies, but it's not just looking at it in the small lens of just the medical field. We have to look holistically at what's going to make these medical professionals go to rural North Carolina and remain there.
Indeed. So, Dr. Fowler, we'll go ahead and let you give your perspective on this question.
Yes. So that's really yes, all that and yes. So you have to make sure their spouse wants to live in that rural county too. Just saying. So my lived experience is exactly what Senator Batch spoke about. I was able to return to my hometown and practice medicine for 14 years. And I practiced full spectrum family medicine, obstetrical care, operative obstetrics, inpatient nursing home. I provided care for 14 years to individuals that I knew my entire life, teachers, loved ones. And it is something that generally works really well if you get someone from that rural county to go back there, because it's very meaningful, but it doesn't mean that other people won't want to. But I was able to do that because of the support of the North Carolina General Assembly, the Office of Rural Health, individuals at that time who provided the ability to practice obstetrics in rural North Carolina because they paid my malpractice premiums. That bill, that doesn't exist now. And women's health. We're talking about aging women, but let's talk about the inability to get obstetrical care in rural North Carolina. I mean, it is absolutely unbelievable. So the programs that have been in place in the past, many of those types of initiatives are being brought back up and brought back to the foreground because we currently have a physician shortage, but it is only going to get worse. The estimations in the next 6 years, the physician shortage is, anywhere from 30 to 80,000 physicians shortage over what we need. But what we need are not necessarily more gastroenterologists and orthopedic surgeons. We need primary care physicians who are interested in going to the places where they can provide the care to give the services to the communities and increase and decrease these adverse health outcomes. The initiatives that are in place, there is absolutely things like loan forgiveness. My hospital was able to forgive my loans, but that was by the hospital. But there are loan forgiveness programs that the North Carolina legislature and some friends of mine have worked on ways to encourage physicians to go back to rural areas. And we really, really need to encourage our medical students to be involved from an early stage. What we also have to do, and it's a broader recommendation, we have to flip the narrative. I have practiced medicine and seen physicians lose the reins. When I graduated, it was expected that you would leave school and open your own practice, which is what I did. That was the norm. It is no longer even comprehended by many people leaving residency. They have over 6 figures of debt, over $250,000 some of these young physicians face. And so they end up in urban areas and they end up in specialties. So we have to flip it. We have to increase reimbursement for primary care so people want to go do that. We have to decrease the burden on primary care. So when a student who I teach and they work with me in clinic don't decide it's a lot easier to be a rheumatologist because they look a lot less stressed than Dr. Fowler. I mean, I heard that from a student. You're amazing. I love all you do, but I think I'm going to go into rheumatology. They get an hour with each patient. I mean, it's demoralizing, right? But so these are the kind of things. It's really infrastructure change, it's structural change, and it's basically making sure that we're training physicians to take care of the communities where we need them.
Thank you. Thank you for that response. And yeah, I just want to say, Dr. Fowler, we love you for what you're willing to do.
You might say, why is she not still there? And I just want you guys all to know the reason I am not still practicing in my hometown is 11 years ago. I started my practice 25 years ago this month in my hometown by buying my family doctor's practice. And he and I practiced together the entire time I was there. When I left, I sold it back to him. He just retired last year. But anyway, I left so I could be here today. I left because try as we might to recruit a physician to my practice, we could not. And I thought, surely to goodness, if I go down the mountain, which is what we call it, down the mountain, I can do something to make change. It's been over a decade, but here I am sitting next to a senator who sounds like a soul that really speaks my language. And hopefully I can help shift it back so we can have more power.
So, I want to flip over now to Mary, um, Miss Mary Bethel. So, Mary Bethel she's a co-chair, okay, of the committee that is working on all ages, all stages. That is the response to Governor's Executive Order 280. And so today, we want to wrap up our individual questions, understanding a little bit more about what that committee's been able to glean, because that committee's been working now for about a year and a half or so, and is right at the cusp of finalizing a report with their recommendations. So the question I have for you, Mary, is, give us some perspective of what were the issues, when you went out and really looked at what was going on across the state with people who are aging. And it's important to say that the work that Mary and the team have been doing is related to all genders aging. It's not just, in a woman's perspective, but we know that everything that they have learned would apply to women and more. When we start to peel back the layers, there will probably be even more. So it's very important to hear the perspective of the report. And so give us today what you were able to share from the multi-sector aging report that's coming up in September.
Thank you. Glad to be here. And so I figured out why I'm part of was a co-lead for this, because I am a face of aging. And the issues I face are things that we have heard from people all over North Carolina that they're facing also. So I bring that up close and personal experience to it. So today, when Governor Cooper was talking, he made the statement that as governor, he is looking out for North Carolina of tomorrow. And I think that's exactly what he did when in May of last year, he signed Executive Order 280 to basically call for a plan. He called for what North Carolina could do to be a more age-friendly state. And he called for a number of actions to take place. And one of those things he wanted to do was the development of a multi-sector plan on aging that would look at how North Carolina could do a better job of providing services and programs for older people, and how this would affect all generations to come too. So I think also the demographics have driven this. Candace gave you a little bit of data, not a whole lot. I've got some notes here because I'm going to share more data with you. And I have never been able to remember data, not when I was 14. So I had to write it down so I could remember it. So just a few things I want to share with you. 88 counties in North Carolina right now have more people over the age of 65 than under the age of 18. And those that don't are usually places that have military bases or educational institutions or places like that. So we are a graying state. In fact, we're ninth in the country in the number of older adults that are out there. Now, if you look at the people over 60 in North Carolina, we have 2.68 million people today. In 2050, that's going to increase to 3.87 million people. Now, just to zero a little bit more about what we're talking about today, women. Right now, we have 1.48 million women over 60. In 2050, it's going to be 2.17 million. So aging is very much a women's issue. And just to give you two examples of that, women outlive men in North Carolina by an average of 6 years. Also, if anyone happens to need care, who's going to provide that care? Primarily women. Usually it's spouses or children or sisters or whoever are going to do that. If it's a paid caregiver, who are the paid caregivers? They're women predominantly, for sure. Okay, in signing this executive order, we decided that it was very important after it was done to bring together people in North Carolina to hear from them, to have input into the development of this plan. And I will tell you that people across North Carolina raised their hand and said, we want to be involved in this. We ended up having about 260 people that ended up being part of 4 work groups that were formed to serve the basis of this plan. And they came from every nook and cranny in North Carolina. We now call the plan All Ages, All Stages. This group worked very hard for about 6 months to get the draft of the recommendations they came up with done. And then it's been the last few months in the hands of the steering committee and leadership to try to massage it and to get it into a formal document that can be used. They came up with 160 recommendations, and they covered the waterfront of anything you can think about that impacts women and their health and well-being in North Carolina. We looked at 4 areas: affording aging, optimizing health and well-being, supported older adults and their families, and strengthened communities for a lifetime. We ended up taking those 160 recommendations and boiling them down to 43 priority recommendations, which are the things that we're going to concentrate on first. There's no way in the world you could take 160 recommendations and say we're going to do everything at one time. So we're going to concentrate on those first. And some of those are long-term type things, but we've got to be able to begin to lay the foundation now to get things done. You know, Rome was not built in a day. So it's going to take some of those things that are going to require, say, some legislative action, some really change in policy and how we do things in North Carolina. You've got to bring people on board with coalitions and partnerships and things like that to get things done. So in order for it to be considered as a priority, we've put a lot of emphasis on what the people tell us their needs were. Where are gaps in North Carolina where we aren't doing things that we should be doing? What are the research and studies showing us that need to be done? And then let's look at the data. You know, we have to be data driven to the extent we can, and we're going to move the needle on a lot of this. So what I want to do now is give you an example of how things are interconnected when you start looking at addressing needs of people in our state, and how some of the recommendations we came up with materialized and how they build on each other. So I want to give you a bunch of kind of background and information about aging in North Carolina. If you ask people, where do you want to live? Most older people will tell you, I want to stay in my home. Depending on what study you look at, 77 to 90% of people say, this is where I want to stay. So one of the things that we need to do is to ensure that we do things to keep people as healthy as possible, as long as possible, so that they can remain their independence and stay in their home if they choose to. We also know that 81% of people in North Carolina live with one or more chronic health conditions. I kid you not, when I was looking at my notes early and I read that, and I went, oh my Lord, I have a couple of chronic health conditions. I forgot to take my heart medication today. So I'm glad I'm sitting here beside you. I think just, being off by 6 hours is not going to cause me to flake out here. So anymore. But when it comes to women, 57% of older women in North Carolina are managing 2 or more chronic health conditions. You heard the information about heart and how that really, it's happened to me, I mean, diabetes, arthritis, just common type things that people have, particularly as you get older. We also know that older adults that want to stay in their homes sometimes don't have the resources to do renovations or repairs or things like that that will enable them to stay there. How many of you have a bedroom on the first floor of your house? Well, it's more than usual. So if you don't have a bedroom on the first floor of your house and you want to spend the rest of your life there, move or build or do something, But we also know that even if people might have a house that can accommodate them, we all have to have house upkeep. And sometimes just the process and mechanics of going through doing all that stuff that needs to be done to keep your house upkeep is daunting. I mean, I've been trying to get gutters for the last 6 months, and it's driving me crazy, So it's just the types of things that sometimes as we get older, they become major challenges that we have to deal with. I mean, just another thing with housing, we've got a lot of people in North Carolina that all of a sudden the property values have gone sky high and they can no longer afford their property tax bills. And we have not changed our property tax exemption standards in North Carolina in decades. So you've got people that are saying, I want to stay here, but I can't afford to stay here anymore. So we refer to people as being house rich and cash poor, that they want to do it, but they can't. We also know that 7 out of 10 people will require some type of long-term care in their lifetime. Now, that could be anything from maybe a home delivered meals or an in-home aid coming in, but it could also they need assisted living, or they may need to have skilled nursing care. And we also know that with those varied needs that people have, most communities in North Carolina do not have a continuum of care. But that, I mean, depending on what your level of care is there a service or resource that can help you? So if you just need to have an aide come in, are the aides available in your community? And I will tell you, the workforce shortage we've got now, it's hard. If you need assisted living, are you going to have to go 2 counties over to get it? If you need skilled nursing care, are they still accepting people in skilled nursing care because they had to close 2 wings because they can't get help? So they're the types of things that we need to be concerned about when you think about where are you going to spend the rest of your life. Now, a couple other considerations also that I want to mention to you is we know that a growing segment of the population is what we call the old. That's the 85 plus. In fact, the largest segment of the population, the old, are older women because they outlive older men. So in North Carolina right now, we have 133,000 women over the age of 85. It's going to increase to 321,000 women in 2050. And then you add the men on top of that. And what happens, that old population are the ones that are going to be more likely to need care and assistance. So, you can see if your grandparents, maybe if you have older parents, their needs are going to change generally as they get older. We also know that people who need any type of care, are they going to have the resources to pay for it? We hear all the time about people aren't saving anymore. We also know in North Carolina that there are a lot of people that don't have the opportunity to save through their employers. We have a bill penned in the General Assembly this last session that would have the state of North Carolina to establish a program to allow people the option to save money at no cost to the employer just to put it away. But care is pretty expensive. Genworth Insurance Company does a study every year about the cost of care. They looked at North Carolina and what they thought it would cost of care for 3 separate levels. One was to have a home health aide for a year. It was over $64,000. They also looked at what it cost for assisted living. It was over $69,000. And if you wanted a private room in a nursing home, it was almost $110,000. Most people, if they have a little nest egg, it does not take long for that nest egg to go away when you're paying out of pocket for things like that. So, which brings up another issue, because people don't have it. A lot of people end up paying out of pocket until the resources and assets are gone, and then they come on Medicaid. Right now, Medicaid in North Carolina is the biggest payer of home and community-based services and nursing home care. 2/3 of older adults in nursing homes in North Carolina are Medicaid recipients. They may not have started out that way, but when that nest egg was gone, Medicaid is now picking up the balance of the bill. We also know that people do not realize that Medicare does not cover most cost of home care or skilled care. It just does not. So one of the things we want to do is to educate people about know what Medicare does cover. And if people, another thing is that if people need care, who is the most likely people initially who are going to provide that care? Children or family, spouses or whatever. Yes, family caregivers are the backbone of our long-term care facilities. Technically, 90% of the care that's provided to people in our state and across our country is provided by what we call the informal support system. And that support system is frayed. It is a tough job to be a family caregiver. Sometimes it can be of long duration. And also, we know that a lot of family caregivers have to stop work to do the caregiving responsibility, or they may have to cut back on their hours. And if they cut back on their hours or are still trying to work, do they have paid leave in order to continue that? Lots of times not. So it's really, really challenging. The other thing that when somebody either stops work or cuts back on the hours, they have the immediate impact of loss of income. But the long-term implications of that is that they are paying less quarters into Social Security, and they're also losing benefits they might have through a 401k or maybe even a pension plan if they're still lucky enough to have that. And so the last issue I will raise also on this is about, and I mentioned it earlier, is about the difficulty in finding workers. We have a critical shortage, and it got much, much worse with COVID. Doing care is hard work, and it's usually low paying, and people now have options, and they're going to McDonald's, they're going to Walmart, they're going to Amazon, they're doing these types of things, and they are not sticking around, many of them now, to do direct care work. So we have in North Carolina right now, it's estimated that between 2018 and 2028, the need for 186,000 direct care workers. New job openings, I guess you would say. Basically, they're saying 21,000 new workers And then the rest of it's from the churn, from the turnover. Many times in people that is like a revolving door. If you talk to people that run agencies or facilities, they will tell you their turnover rate exceeds 100, 200% many times. So in closing, I just want to say, so all those things play into what the needs of North Carolina is. So what we did in the development of this plan, we looked at all those things and we came up with recommendations about things such as how are we going to keep people healthy? How are we going to help people save for the retirement and for the long-term care costs? How are we going to help them stay in their homes if they need renovations and repairs? How are we going to address the direct care workforce shortage? How are we going to support family caregivers? How are we going to work with communities to consider they have a robust continuum of care? And how, as a state, can we plan ahead so that we can ensure that all North Carolinians, and the middle class included, that they can have options that they want, that the care will be there when they need it, and the services will be there when they need it, and there's ways to financially pay for it that's not going to bankroll the state in the process. So we're excited about the plan. It's now going to be in the governor's hand in a couple of weeks. And it's now the responsibility is going to be, we have got to operationalize it. I have been around this world and this work world a long time. I've seen 100 plans sit on a shelf someplace. We do not need a document that's going to sit on a shelf. We have got to operationalize it. It's got to be a fluid document that changes with the times, and it's got to be our roadmap for how we want to move North Carolina forward if we're going to do it. Otherwise, we've wasted a lot of time.
All right. Thank you, Mary. Oh. Is that not the walking dictionary? The walking wealth of information on what you need to think about with aging. And so, you know, in talking with Mary and this entire panel, I just want to reiterate one thing that dawned on me very, very quickly. You cannot wait until you're 50 to start planning. So with all of the different issues and things that need to be sorted out that Mary went through, all those elements, and as you see back here on our honeycomb, you have to start early. And so, you know, I would dare say even in your 20s, but it's hard to convince somebody in their 20s that they need to think about when they're 50, 60 and more. So, but anyway, but do you agree with me on that? Add on top of what Mary said, the fact that women actually make less than men. We're outliving them, so we're definitely needing the funds longer, but we actually make less than men. So that concludes our panelist questions, but I'm going to go on to two of the questions that we have selected from the audience, and we actually are quickly running out of time, so I'm not sure that we'll get to both. Okay, this question says, where does the intersection of menopause, health equity, and workplace policy for North Carolina get addressed? That might be, I'm not sure.
It's not in my office, so
And
I talk about menopause all day.
Sure if it's been looked at in that way, but I'll pass it to you, Senator Bass. You think you can give us a little bit of perspective on that?
What I would quickly say is that if you really want to affect what actually happens with regards to women's health, then you need more than 25% of women serving in that damn legislature. I mean, people care about their issues. And at the end of the day, we serve with a lot of men who do not, who were born of women, last time I checked, but don't always believe that our issues are the ones that are the most important. And so we really have to change the face of what happens. I will also just say that legislatures that actually have a majority of women, or they finally get over like the cusp of 35 to 45%, have better policies that actually help all people. So God forbid women actually think about their entire family instead of just themselves. So my answer is, in order to, you know, outside of getting on really good menopause medication like I'm on right now, where you can talk to Dr. Fowler, I would say getting more women in office and electing them into all of the different levels, and also in boardrooms, and also in the health insurance companies. Everywhere else, we need to be in that position because they need to be running stuff, not legislators making decisions that doctors should be making in the first place.
All right.
And the comment was made earlier about being in the room, the table. I don't want to be in the room. I want to be at the table, and I want to be at the head of the table.
Head of the table. Amen.
So that's what we need to do.
At the table, you're on the menu.
All right, we've got one more. I think we may be able to sneak it in just under the timeline. I work in the field of dementia and autism. Are there research initiatives or policy work groups working not just on solutions for women living with these conditions, but really focus on the health and economic impact of the caregivers? We tend to see the caregiver get sick and has to quit work really often. Any comments from either of you on that one?
We have filed, and I have filed multiple bills, including, Age with Dignity Act, which allows for caregivers to actually get, God forbid, tax credits for being able to take care of their loved ones, which disproportionately helps women. It is sitting in the Rules Committee and is not moving anywhere. So hopefully somebody else will take that idea and run with it and take all the credit. But those are some of the things that we can do, because at the end of the day, and paid leave. I mean, we need to pass paid leave, because if we have that, then you actually change the trajectory of most people's families. It lifts all boats, gets most people out of poverty, and allows for them to keep their loved ones in the home for a longer period of time.
And one comment I'll make, and I have seen this over and over in my career, it's quite often that the caregiver dies before the person they're giving care to. And that can be a spouse who's actually sicker initially than their caregiver. But this is the burden of chronic stress on women from all aspects of their life is profound, and it affects their health every day.
We are right on the timeline. But before we leave, let's give a huge round of applause to this wonderful panel. Yeah. And I'll just personally say to each of you, I have learned so much, in our time preparing for this panel from each of you. Just a reminder that we'll take a short break, and then we'll be back in room 1 for our final plenary and keynote speaker.